Get started. I am Dr. Rama Warsami, and it is my absolute pleasure to introduce my good friend. One of my only misses during my Mayo Clinic residency and fellowship is that I did not meet Dr. Jasmine Marcelin sooner. We met on her last year of training and were co-founders together to start the MFA Diversity and Inclusion Committee. So it's really nice to see how much it's grown. Dr. Jasmine Marcelin is an assistant professor, co-director of the Digital Innovation and Social Media Strategy, and Associate Medical Director of Antimicrobial Stewardship at the University of Nebraska Medical Center. She is a Caribbean native born from Dominica. Dr. Marcelin received her medical degree from the American University of Antigua College of Medicine before completing her internal medicine and ID fellowship here at Mayo Clinic, Rochester. During her time at Mayo Clinic, she was a Chief Infectious Disease Fellow and co-founder of the MFA Association Diversity Inclusion Committee. Dr. Marcelin is also the founding member of the IDSA Inclusion and Diversity Committee Equity Task Force. Dr. Marcelin is a passionate advocate for diversity, inclusion, equity in medicine, and is requested speaker on unconscious bias and diversity and inclusion in medicine. She's also very good at social media and use for healthcare professionals. You can follow her at Twitter. She is at Dr. J.R. Marcelin. And with that, I will let her take it away.
Okay, can you guys hear me? Great. Thank you for the very kind invitation, Dr. Warsami. I also regretted not getting to know you earlier in my training. And I want to thank the MFA Trainee Diversity and Inclusion Committee chairs for inviting me. What an honor to be invited back as a keynote speaker for your inaugural Diversity Week, and knowing that you guys have done so much. Hats off to you guys. Thank you so much for what you've done for this committee. So I'm going to talk to you guys about unconscious bias and challenges surrounding unconscious bias in medicine. And I like to keep my talks a little bit interactive. And like Dr. Warsami said, I do use social media a lot. So you'll find little Twitter birds on my slides with my handle. Feel free to live tweet or not live tweet after the fact if you want. But just tag me if you do so, because I love to continue the conversations afterwards. So my objectives are listed here. We're going to talk a little bit about unconscious bias. And then we'll talk a little bit also about the bystander effect and how to respond to unconscious bias and microaggressions as a bystander. And then talk a little bit at the end about how to address unconscious bias from a personal and an organizational level. So some housekeeping for how to be interactive with the polls. If you have mobile devices, please pull them out. Like I said, I love the social media, but also for the polling, it's really helpful if you can use your social media, your device. And these are the ways that you can access the polls, either through the website or there's a Poll Everywhere app. You can also send a text message to the number there. This information is going to be on every slide that has a poll, but I just wanted to give you a chance to log in and get into the classroom. While you're doing that, a couple things that I wanted to tell you about this particular talk. Unconscious bias is a really wide and deep topic, and a lot of the things that I'm going to be talking about are through the lens of where the most of the data is regarding gender bias and race and ethnicity. I will touch on other areas that do have some bias, and there's some limited data in terms of healthcare professionals, but there will not be as much on that because it's, again, very limited. And that brings me to the next housekeeping thing is that, again, with the depth and breadth of unconscious bias, we can apply this to healthcare providers as well as patients. And this talk is really going to be focusing on healthcare professionals. I recognize that there is a wealth of data on disparities and bias for patients, but we have very limited time today. Okay? So with that being said, I'm going to jump right in and get started, okay? first things first, I wanted to get a sense of the temperature of the room. This is a talk about unconscious bias. And so the first poll I wanted to see, what are your experiences with unconscious bias or implicit bias? Have you experienced it yourself? Or perhaps have you witnessed it? Maybe you've neither witnessed or experienced, but you're aware enough that it exists. Or are there people in the room who need to be convinced that unconscious bias is a problem? So if you go ahead and we can see kind of how people are responding automatically, and it looks like so far a lot of people have personally experienced unconscious bias or they've witnessed it. Okay, so a fair number of people have personally experienced unconscious bias. When I do this as a workshop in smaller settings, I like to touch base with the individuals in the room to share some stories. We won't be doing that today, but throughout the talk, I may share personal experiences or things that I have witnessed as context, okay? So let's start off with a story of bias. I'll give you one from a long time ago. I'm from Dominica and grew up in Antigua. After I left the island of Antigua to go to my undergrad training, I went to Halifax, Nova Scotia. It was a big jump, and I had never been to North America before going to Halifax. And I remember being in a chemistry class, and there were about 5 or 6 of us who had come from Antigua together to this program, and we're all in the same class. And we noticed that we were consistently getting C's on our reports, our homework, our assignments, regardless of what we did. And we kind of compared with some of our colleagues who were in groups with us, and they were not getting C's, and the work that we were doing was comparable. And in this particular class, there was a lot of essay writing and derivation of equations. And so some part of it is a little bit subjective, but it was kind of odd that we weren't getting higher grades than C's. None of us ever got more than a C. My colleagues and I, we kind of discussed whether or not we would say anything, and we decided that we wouldn't until there was one particular assignment that I knew for sure that I did better than a C on. So I called out the professor, and his response was, well, I don't really expect you guys to get more than a C anyways. You're from the Caribbean. And when he said that to us, I didn't really know I didn't know how to respond. I didn't know what to expect. I didn't even know that professors were allowed to say things like that to their students. But I didn't really feel empowered to say anything or do anything. Neither did the other people who were in the classroom with us. And this happened in public. And needless to say, I still ended up with a C overall for that class, and I was not very happy about it. But I didn't realize that I was experiencing bias at that time. I literally thought that university was hard, and that I just needed to work harder. And so the thing about bias is that it can come in many different forms, and sometimes it can be quite explicit, sometimes it can be implicit or unconscious. And a lot of the ways that it is manifest is through what we call microaggressions. And so what you see here listed in front of you are some images of individuals with the placards calling out the microaggressions that they have experienced themselves. So the one on your right, the young lady saying, "My hair is real." That's something that I personally have experienced, where people question whether or not my hair is real and want to pull to see if it's real. And it's the intent is unclear as to whether or not an individual may actually be questioning, hey, I'm not really used to your kind of hair, I want to learn about it, versus I'm just going to reach out and pull your hair. Some other things that I've experienced, I've listed up here, that include, me being from the Caribbean, people are wondering why my English is so good, and being surprised when I say English is actually my first language. And so we'll talk a little bit later on about how to address some of these microaggressions, but these are things that I'm sure many of the people in the room may have experienced in some form or another, even if you may not know that that's what you were experiencing. And so when we think about race and ethnicity and disparities and bias, something that has been more in the news recently is the maternal mortality in the United States in general, and how that is worse than it really should be for a developed country, but how bad it is for women of color. And so this has been going on for a long time. ACOG has recognized this, the American College of Gastroenterologists have recognized this, and, AMA has recognized it. And there are many studies that are showing that there's worse maternal mortality in women of color. But it seems like we really started talking about it recently in the last couple of years when different celebrities have been expressing that they experience bias during their hospitalizations, for their pregnancies. And it seems like if it were not for some of these headlines, the conversation wouldn't really be in the forefront of our minds. And while I did make the caveat earlier that we're not going to get into some of the racial or ethnic or any other types of disparities from a patient standpoint, I listed this as kind of one of my initial slides because I wanted to share with you that the bias really is pervasive and it can affect everybody in the healthcare spectrum, regardless of if they're a patient or a healthcare professional. So what do you think about when you hear the term unconscious bias? This is a neat little presentation that's going to show up with a word cloud. So if you use your mobile device to log in, if you type in one word at a time, it will show up. If you type in a whole sentence, it will make each word come up. And so think about short phrases that you may think of when you hear unconscious bias. And let's see kind of what happens here. So microaggressions, prejudice, and what's going to happen as people are saying words over and over again, the words get bigger. And the more times people say a word, you'll see what themes sort of start to show up in people's minds. Prejudice and discrimination, so far, sort of the big words that are coming up when people think about unconscious bias. I asked this question to a different group a few days ago, and some of the big words that came up for them were racism and gender. Unrecognized. I could actually stand here and just watch it change all day. I think it's really pretty the way that it shows up like this. We're gonna keep moving though. But thanks for sharing some of your thoughts on, what comes to mind when you hear about unconscious bias. So we're gonna delve into this a little bit more. So unconscious bias is really the associations, the attitudes that we develop based on different characteristics of people before we've even gotten a chance to know who they are. Okay, and so there is a diversity expert, Verna Myers, who described it as the stories that we make up about people before even getting to know them. And that could be because of their race or ethnicity. It could be because of their gender. It could be because of their sexual orientation or their gender identity. It could be because of the language that they speak. It could be because of a disability, whether it's visible or invisible. When we meet people, we make up a story about them immediately. And that happens for everybody. And it's up to us as individuals to decide on whether or not the story we make up is the story that stays, or if we would like to actually invite that individual to tell us their story, right? So bias is really our nature. It's something that everybody has. Bias is not something that is just for people who are racist or bigots. Everyone has bias. Everyone in this room has bias. In fact, there is something that I like to say. I think I said it first on Twitter a few months ago. Show me someone who says they have no bias, and I'll show you someone who has no insight. Everybody has bias. There's actually an evolutionary nature for bias. We needed bias to survive. If you think back to our ancestors, let's go, I like to tell stories about people living in villages because, villages are something that still exists for us in the Caribbean, and you can go from one place to another pretty easily on foot. And so I like to think about ancestors being in villages and you being in your area and noticing a strange animal coming towards you. The animal is large-ish. It has claws. It has fur. It has teeth. But you're not quite sure if this is the type of animal that you can kill or to eat, or will kill you to eat you. And so you have to make a split decision. That split decision is going to be based on previous experiences. Have you been attacked by animals of that size with teeth that large who have had a certain color fur? If that's the case, you may be more likely to run than try to engage with this animal. Same thing if you saw somebody, a human walking towards you into your village and you've never seen this person before. You have to make decisions about whether or not that individual is going to shake hands with you and try to break bread with you and maybe share or barter with you, or if that individual is going to try to pillage your village. And your decision making is going to be based on whatever construct your brain has created from previous experiences. The previous experiences may not necessarily be your own. It may be what has been told to you from the senior people in your community. It may be what you have witnessed. You may not necessarily have experienced it yourself, but those connections are still being made. These things were necessary for us to survive. Now, in 2019, we're not necessarily dealing with those same situations, but one could argue that there is still very much a need for survival that comes with unconscious bias. If you think about the number of young people of color who have been killed because of bias. It's one of those reasons why I've always been, since I've become a mother of two young black boys, I've been nervous about them wearing hoodies. Just when I try not to buy them for my sons. And I get nervous about my husband doing a long drive late at night because I'm afraid he's going to get stopped and he might not come home. And so you can argue that bias is still a life or death situation. So just a different life or death situation. The associations that we make in medical school are a product of bias. Now, when I was, as I started reading and looking into what implicit bias really is, I really started to think about those learning associations from med school. And so think about the stereotypes and studying for USMLE exams. When you're studying and you see a question that says, a young African-American child coming into the hospital with pain, what's the first thing that comes to your mind? Sickle cell, right? Or a young white child who has recurrent respiratory infections, thinking about cystic fibrosis. So the problem with that is these associations are based on general prevalence of these diseases in certain groups, but when we take the associations on their own and only rely on those stereotypes, that can lead to premature closure and misdiagnoses. So there was a letter to the editor several years ago that was written by a physician who told a story of a young child who had been, it was a young black child who had been diagnosed with cystic fibrosis, I think based off of just the x-ray. And so the child had been coming into the hospital with problems, and nobody thought to check for cystic fibrosis. And one day, maybe on the 8th hospitalization, the radiologist was reading the chest x-ray, and somebody walked by and was like, oh, who's the kid with CF? And they looked and were like, what? No, this is not, this is a young, like, this is a black child. And he's like, well, that looks like CF. But the clinicians were not thinking about that. This is something that can be pervasive in healthcare, and we have to really think about how we view these stereotypes and come up with some sort of constructs to help us to pass our exams and to recognize the common things, but not shut out the uncommon. Okay? Disparities are everywhere in healthcare. And there are many studies that actually have looked at bias itself, unconscious bias, and how that affects the treatment of patients and our interactions in general. So there's a study that looked at the talk time between patients and physicians and found that physicians who had an unconscious bias against a particular group allowed them to speak less, allowed the patient to speak less. There was less eye contact with the patient. There was a less welcoming body language. And at the end of it, the patients felt like their needs were not listened to, and they were overall unsatisfied. There's also many studies that are looking at, whether or not people are getting pain medications, people are getting the correct cardiovascular interventions, and correlating that with their unconscious bias as diagnosed by this implicit association test. So the implicit association test is a psychological test that was described by some psychologists. It's coming out of Harvard. The Andy Greenwald and Mazarine Banaji, they looked at whether or not individuals can have a bias that they are not even aware of towards different characteristics. So you can see that there's many tests that a person can take. And how it works is they ask you to categorize good words and bad words with different people characteristics. So good versus white, bad versus black, and vice versa. How it works is that they're counting the time that it takes. How long does it take for you to categorize good with white, bad with black, or bad with white, good with black. And if it takes you longer to categorize bad with white, good with black, then you have an implicit white preference. It doesn't mean that you're racist at all. It means that unconsciously, your brain is wired to associate good things with people who are white. It means that your brain unconsciously is wired to associate bad things with people who are black. And that's just one test. There is a really interesting gender family career test that looks at whether or not you are more likely to associate women with staying at home with the family and men with being career individuals. There's also a very interesting weight bias test. A lot of the people, when I do unconscious bias workshops, a lot of people take the weight bias test and are really surprised about their own unconscious bias towards people who are overweight, even when you yourself may be overweight. So that's the other thing about unconscious bias, is that because it's a construct of what we've experienced and the life that we've lived and what we're seeing, even if you may be a part of that group, you may still demonstrate a bias against that group. It's very interesting. So a lot of people who take the implicit association test end up being upset because they think that it means that they are racist or that they're sexist or that they're some other ist, when really what it is telling you is that you have an opportunity to look deeper into your bias and look into yourself and how you actually describe, how you see the world, how you view the world, and how that can affect the way that you move through the world. So I can't talk about the implicit association test without letting you know that there's controversy about it, okay? It's not all good things that are being written about it. There's actually been quite a few dissenters that have said that there's not as much of an association with the IAT with specific behaviors. Like it cannot predict everybody's behavior. That's true. It cannot predict everybody's behavior. What it can do is shine a light onto your own individual behaviors and maybe help you to think a little bit if bias may be responsible for some of the things that you've done or said. I'll give you a personal example. So I took the gender family career test, and my results were I was biased actually against women who stay home, like the gender family, women family. And I was surprised because most women who take the test most professional women who take the test actually have the results saying that they prefer women with family, not women with career. And so I got this women career one, and I was like, yeah, okay, cool. I'm not biased against women who are professionals, and I'm a woman professional, so that's good. So then I started thinking about what does it mean on the other side. And I recall that I had made, snarky comments every once in a while about my people in the neighborhood who may have been stay-at-home moms. And out of frustration, because as a working mother, I have children, I have a child in elementary school and I have a child in daycare, and then timing and things don't add up, and, great things are happening at 10 o'clock in the morning and I'm at work. And so I make comments about, well, why is it that they have to act like everybody is a stay-at-home mom? And maybe that's an innocuous statement, but the intent behind that statement was not necessarily to disparage mothers who are at home, because I know it's a full-time job to be at home with your children. But is it because I had an implicit bias against mothers who stay at home. And so it really helped me to think a little bit about how I view my relationships with moms who stay at home. And I'm very good friends with several, and trying to make sure that I'm aware of the interactions that I have. And the place where I actually came out was when I was talking with my sister-in-law, and I made a comment, and she was like, "Hey!" I was like, "Oh, I don't mean you." And then as soon as I said, "I don't mean you," I was like, "Oh my God, I'm one of those people." you know which people I'm talking about, right? So it really helps you to think through your own biases and help to change your own personal behavior. Okay, so now I'm going to switch gears a little bit to go run through some of the different types of bias. We're going to talk about race bias, we're going to talk about gender bias, we're going to talk about bias for LGBTQ and sexual gender minorities and disabled physicians, and we'll kind of whirlwind through a lot of these things, okay? So I have one more question coming up for you for race bias. Have you ever applied for a job and wondered if your race or ethnicity factored into the hiring process at all? Now, I intentionally left it vague, so not necessarily that you didn't get a job because of your race. It could be that you think maybe you did get a job because of your race or ethnicity.
Jasmine, some of us are too old and don't know how to do that.
So,
age bias.
Well, Dr. Kasten, I apologize. Here are a couple other options that you can use. You can send a text message. Oh, is that, Park, are you going to help her out? Yeah. Thank you. Perfect. Okay, so looking at the results, it seems like most people have wondered about this. But there is a healthy few that know for sure that has factored into not getting a job. This is a really interesting question. This is a new question that I put in for this last few talks that I've been giving. And I think, had this been in a different setting, it would be really nice to explore some of what people are thinking. But it's really interesting to see the dynamics of what people think may be going on with, different jobs. And there's a reason why I bring this up. Race does play a role in hiring. And this is an older study, but it's a study that has been replicated, and I really liked this particular one, so I kept it in even though it's older, where the CVs were exactly the same, and the only thing that was changed was the names. And so what names that sounded white-sounding names, Emily and Greg, what names that sounded black-sounding names like Lakeisha and Jamal, and see who gets called back. And it turns out that Emily and Greg, even though they had the exact same CV as Lakeisha and Jamal, got called back 50% more of the time than Lakeisha and Greg and Jamal. Why is that? The authors went through all of the information. Remember, everything is the same. And these are all fake people, by the way. So they're all fakely good candidates. And so with all else being equal, the authors can only conclude that the reason why there is a difference in the callbacks is because of the perceived race of the candidates. So this is problematic when you think about this being a blinded process, almost, right? You don't see anybody's photos. Lakeisha could have been white. We don't know that, right? But it's the perception of what her race was. Can you imagine what that's like now with medical school admissions, where the photo comes with the application? or residency admissions, where the photo comes with the application. How does that factor into the healthcare professional pipeline if, without even seeing a candidate, by just what their name is, we may treat that application differently? There's another study that I didn't list here that actually went another further, and they had the applicants change their names, and when they changed their names to a more white-sounding name, then they got more callbacks. And so this is actually a phenomenon that it occurs called whitewashing of your CV, where people, so in terms of name changing, what's been noted is that people who are of Asian descent, who may have another name, they use whatever the English Caucasian sounding name is, and that will get them more callbacks. African Americans will remove things from their CV that call out the fact that they're Black, like being a member of SNMA or being a member of the Black Caucus for whatever undergrad that they were in. And that is an attempt to try to get their CV to be as similar to a white individual's as possible, so just so that they have a chance. Now, if you might be thinking, why should a person have to change their CV just so that they have a chance? Take that thought into what we could possibly do for our students, for our applicants in the future to try to help them, give them that level chance. We'll talk a little bit more about that later. So I did a Google search for doctor. Google Images. This is the first line of the photos that comes up. Anything stands out? I was actually surprised. I was fully expecting to not be able to make my point because, you know, in 2019, we have a lot more diverse physicians than we did a long time ago. So I thought I was going to have to like fudge a little bit, but I didn't. I promise you I didn't. This is the first line of what... None of them are Mayo doctors. So why did I bring this up? These two physicians here are physicians who experienced bias on Delta Airlines flights when responding to in-flight emergencies, separated by about 2 years. So the one on the left, Dr. Tamika Cross, was an OB-GYN resident when her incident happened, and she, you know, the individual on the plane had an emergency. They called for a doctor. She showed up, but they didn't believe she was a doctor. They wouldn't let her help. And because of that incident, so she went, she complained on Facebook. Then there was multiple news stories. Delta released a statement, not really apologizing, but saying that they were going to do diversity training for all of their employees. And then 2 years later, Dr. Fatima Cody Stanford, she was leaving Harvard after just giving a talk on unconscious bias. And then she was on the flight emergency. She had her credentials with her because Dr. Cross didn't have hers and was questioned. And so she brought her credentials with her, and they still questioned that she was a doctor, even after the diversity training. She took it to Twitter and there was a really big outrage, and that kind of sparked the what a doctor looks like hashtag on Twitter to really try to raise awareness that, you know, doctors don't look like the first picture. Doctors are more diverse than that. So what is it like to be a physician of color? There's AAMC did some surveys for graduates and found that many graduates are experiencing bias. They're experiencing microaggressions from nurses, from faculty, from patients. Did my thing just, okay, I thought, okay. All right. So the graduates and students are experiencing this. In admissions, we touched on this a little bit earlier. So at Ohio State University, Dr. Quinn Capers did implicit association testing for the admissions committee and found that from a faculty standpoint, even though there was no evidence of explicit bias towards people of color, there was implicit bias. And we'll talk a little bit about what happened after having people take the test and go forward with that. But it's something that, thinking about admissions, if the people who are admitting students into the medical school are biased, then what does that mean for the students who are coming into that school? Then there's another study looking at the experiences of minority residents and some of the microaggressions that they've been experiencing. And it goes back to some of the things that we talked about earlier. There are just daily microaggressions that minority physicians are experiencing. There's a minority tax where minority physicians are being asked to do disproportionately more and be on more committees and do things that are not as helpful for their overall career development because they are the minority. And that is taxing on residents, fellows, attendings, everybody. So that was kind of a whirlwind through the race bias. There's so much more that I could talk to you guys about, but we need to keep moving. And so this next group is going to be the gender bias. And a lot of the things that, again, a lot of data out there. We have a gender equity expert among us, Dr. Julie Silver, and so there's a lot of data that you can look. I'm only going to show you a snapshot. So this is one looking at letters of recommendation. So we know that at every stage of our medical careers, we need letters of recommendation for us to proceed to the next stage. And so this was one particular study looking at the language in letters of recommendation for transplant surgery fellowship, and whether or not some letter writers were more likely to use words that are associated with leadership and strength. We call these agentic words, and those are the words that are more associated with the letters that are written for men, as opposed to some of the more communal terms, which were more used for women, including things like friendly and compassionate and delightful. And none of these words are bad words, but when we value words like leadership, like potential, like star, like bright future, when we value those words, and those words are used more for men's letters of recommendation than other words, then it means that we are devaluing the letters of recommendation for women. And if we're thinking about this from a promotional standpoint, what does that mean if the promotions committee is really looking for that person with potential who is a bright star, and maybe that woman is a bright star and has potential, but the words that are being used are delightful, right? I mean, delightful, you can't say delightful without smiling. It's a beautiful word, but does it help me get promoted? No, it doesn't, right? And so there's other studies that have looked at the individual, the text within the letters of recommendation, and found that there's more of a family context and more personal information in women's letters of recommendation. Like, she did really well despite having 3 children at home, or something ridiculous like that, right? And yes, being a mother and having children at home to take care of and being a professional is it's hard. And women, mothers who are professionals should be lauded for that. But when it's written in a letter of recommendation, it actually weakens the letter because it makes it seem as if you're not focused on whatever it is that you're supposed to be doing. Okay, so this is a huge area for gender bias. What about patient satisfaction? This study looked at the Press-Ganey scores for obstetrics and gynecology. And I found this to be really interesting because OB-GYN is the one specialty where there are more women in obstetrics and gynecology than men, and men feel like the minority in obstetrics and gynecology. And there are many women patients who request women gynecologists. So you would think that, okay, well, there are more women, and women patients request the women, so women patients must love the women. Well, this doesn't actually correlate with that, right? It shows that the men were more likely to get better scores. Why is that? There's a lot of things that can be looked into it. In studies like this, we have to take, we really have to dissect them and think about what are the factors that are being accounted for, how stringent can we be. Unfortunately, with gender research and any sort of bias research, we really have to hold it even sometimes to a higher standard where we have to make sure that we can prove beyond reasonable doubt and maybe even more than reasonable doubt that this is actually due to bias, because it will get torn apart by reviewers and editors because otherwise it just sounds like we're saying stuff because we're emotional. And I should have there was a tweet that I should have put in there from yesterday. I just found this random, I found a random letter to the editor that Dr. Moschler and her colleagues wrote last year or the year before in response to an article saying that men were better at running codes than women, and published in a major medical journal, and there's a lot of flaws to it. And I commended them for writing a really well-written letter to the editor, and there was another well-written letter to the editor pointing out all of the flaws in that study that came to that conclusion. And the author's reply was, "You guys are being emotional." And so there is a different standard that people are being held to whenever having these discussions about gender and bias. So grand round speakers. There's another study that has come from this institution, right? Dr. Hayes. I didn't realize all of you guys are going to be in the audience when I put this together, but it just kind of worked out. So the study that I was going to tell you about, it comes after this, but this is a study that looked at the distribution of grand round speakers, and with reference to the number of women that are in that specialty. And amongst all of the specialties that were studied, obstetrics and gynecology was really the only one that had more women than the reference of number of more women speakers than were percentage of people who were within the specialty. And then in the study that was done from Mayo Clinic, the grand rounds speakers were less likely to be introduced professionally using their title if they were women. There's bias everywhere, okay? What about sexual and gender minority bias? There's, again, not a lot of data, not a lot of information, but what we can see is similar trends in terms of what are the perspectives of people from the LGBTQ community in terms of isolation, feeling like they belong, and whether or not they feel like other people are welcoming them. And when you read through the data, what's out there on the LGBTQ community, the themes are very similar. Feelings of isolation, feelings like they're not being mentored, feelings like they are alone in the institution. And whether or not some of those may factor into decisions that are made about them participating in different activities. And a lot of people from the LGBTQ community don't come out when they're on the interview trail, when they're in residency, when they're in fellowship, because they're afraid of what the repercussions may be. And then disability bias, even less, but there are studies that are looking at more of a qualitative, what are the experiences of people with disabilities? And again, very similar themes, people feeling like they're being treated differently because they're disabled, and sometimes even confusing messages about what diversity actually means and whether or not diversity includes people who are disabled. The thing is, diversity drives excellence. There are many studies that have shown that communities, boards, organizations do better when they have women and minorities that are a part of their boards. And so it means that we really have to try to move towards diversity and inclusion in order for us to be excellent organizations. So how does this happen? How can we address unconscious bias to actually impact diversity and inclusion? So here's another poll for you guys to participate in. How comfortable are you with addressing unconscious bias? When you see microaggressions, when you see things occur, how comfortable are you with addressing it? Good. Good. So, most people are somewhat uncomfortable with it. That's expected. I challenge you to lean into the discomfort. It's uncomfortable. People don't like to talk about it, but we need to talk about it. So hopefully by the end of this last few things that I'm going to talk to you about, we'll have a little bit more of comfort with dealing with bias and microaggressions. We need to be able to address unconscious bias in order for us to get to equity, whether we're talking about gender equity, whether we're talking about race, ethnicity, whether we're talking about equity for people in the LGBTQ community, people who have disabilities. We need to be able to address the bias in order for us to get to that equity. So some personal strategies. Deliberative reflection is really helpful. Thinking about what the stories that I was telling you about when I took my IAT, and I recognized that I had a bias against women who were mothers living at home, and really reflecting on that and thinking how has that affected my interactions, and how can I really change my interactions going forward, right? Questioning the stereotypes. When somebody says X, Y, Z is a stereotype of whatever, then question, well, why do you think that? Somebody comes up to you. I was reading something earlier when a person of general Asian descent, they didn't know what the person's ethnicity was, and they asked them what kind of rice is in like sushi rice or something. And they're just making an assumption that just based on how a person looks is not right. But if you witness that, and if you're the one who finds yourself doing that, take a step back and questioning, wait, why did I think that it was okay to say that? One of the ways, we talked a little bit about recommendation letters. So the University of Arizona has this really nice setup where you can look at some strategies to writing your letter of recommendation to make it an unbiased letter of recommendation. But another tool that I found was this Tom Forth tool to check your bias. And you can literally cut and paste your entire letter of recommendation into that space. And then it will tell you how many male dominant versus female dominant words that you use. And when it says male versus female dominant, we're talking about this agentic words versus the communal words. And I've done this a couple times, and I thought I was such a great letter writer, and then it showed me that some of the words that I was using, even though I felt like, well, those are great words, but in the context of writing a letter of recommendation for a woman, if those words, I'm not saying that we need to eliminate them completely from our letters, because some words are still important. Teamwork, caring, like those are important traits, especially for young doctors, right? But it's what the balance is, right? So this is a useful tool to kind of just check and see and play around with when it comes to writing letters of recommendation. Okay, so I'm going to skip this one because microaggressions is we kind of talked through what microaggressions are, because I really want to get to the next slide, which is how to counter unconscious bias as an active bystander. And so an active bystander is the individual who witnessed some microaggression occurring, where someone says something that isn't right or does something that isn't right, and you feel in your heart that this is not right, and I don't know what to do. And so I've adapted this from the Ohio State University. The Kirwan Institute has a huge resource on unconscious bias. You should really check it out. If you just Google Kirwan Institute, Ohio State University, you'll find this wealth of information on bias, not only in healthcare, but across multiple facets of society. So they have this unconscious bias bystander toolkit, where it really kind of starts with acknowledging that what you just witnessed was biased. And so, hashtag that's bias, right? And then deciding that you're going to do something about it. Once you've decided that you're going to do something about it, then you can take a few different steps and strategies to actually counter that bias. And there's different ways to do it. So humor is one of the ways that an individual can address bias. So like we talked about my English the other day, earlier today, and I said, oh yeah, English is my first language. What's yours? There's a smile on my face, right? But it doesn't work all the time. And so there's different strategies that you can use. And a strategy that I really like that I just found yesterday on Twitter. Guys, Twitter is a really amazing thing. Like, it's another talk altogether. But like, there's a lot of information, useful information. So yesterday, I think it was yesterday, that Dr. Mosher tweeted about what was it, a workshop or? Right, as a lecture that was being given. Dr. Warner came up with this grit as a way to address unconscious bias. So you see it here. So gather, restate, inquire, and talk it out. And like really thinking about what did you mean when you said X? Did you mean this? Because a lot of times people don't realize that what they're saying has the impact that they're saying, that it has. And so that's the big thing with unconscious bias, is what is the intent versus the impact. So from addressing as a bystander standpoint, really pointing out what that impact is to the individual can be helpful. So an approach that I've used is, look, I know you didn't really mean for it to sound like this, but this is how it came across to me. And this is how it landed on me. And so, I mean, you and I were just together, but I would be afraid if you said that in public that people might really think that you meant X. And a lot of times the response is, oh my God, that's not what I meant. Because people really don't know. That's why it's unconscious. And generally speaking, when I've tried this, people have been very receptive and apologetic. And then the next step is really thinking about what can I do next time. I gave a talk in the end of March, and I was wearing a beautiful red dress. And I was wearing these shoes, and I had my hair done differently, and I was sitting at the back of the auditorium on my computer preparing for the talk. And some people walked past me, didn't really say anything, and I went up and I gave my talk, and I came back down after my talk, and one of the people in the audience came up to me and said, I need to tell you that I had a moment of bias when I first saw you. You were sitting in the back, and you were dressed really, really nice, and you looked really pretty, and I thought you were a drug rep. I did not think you were a doctor. And then I saw you go up there, and I thought, oh, what is she doing up there? And then you started talking, and I realized you were a doctor. And I was like, I'm not sure if that's a compliment but we kind of talked it through. And he said, no, I recognize that I was biased because I saw a well-dressed young woman and immediately did not think that she was a doctor in a room full of only doctors. And I am sorry. And we had a really great conversation after that about it, and he even went on to create this bias tool for his residents to take back to his residents to teach them about what he learned. And so having these honest and open discussions with people about their biases can be really helpful. As an organization, there are many things that can be done, and a lot of it has to start with leadership and being intentional about the strategy and also being very transparent. It doesn't mean that there needs to be diversity trainings and then you check a box. So your annual training, stick in something with diversity is not going to cut it for really getting to the meat of unconscious bias. And in fact, studies have shown that diversity training alone, it actually can have the opposite effect and normalize stereotypes and make people behave in a worse manner towards minorities. So diversity training can be helpful, but it really needs to be paired with an intentional strategy to support people who are minorities who may be affected. And when I use the word minority, I mean it in a very broad term, and it could be gender, it could be LGBTQ, it could be race, but really there needs to be something else in addition to the training in order for this to be successful. So treating diversity and inclusion as an innovative challenge is one of the first things, one of the most important things to really make some sort of headway. And so, this diversity week, the MFA Trainee Diversity and Inclusion Committee, this was born out of a group of us kind of thinking, can we just get together more? Can we find our way together? And can we show medical students that are visiting that we like to be here and that we feel like we belong here so that they can feel like they belong here too? And that's one of the innovation challenges that the MFA accepted 3 years ago. So if you choose to make it a challenge, then they will be more successful in actually having some sort of effort that kind of results in something positive down the line. So then changing the institutional norms, going back to Dr. Capers, what they did was they had all of the admissions committee members do the implicit association test. Then they had them do their normal recruiting. They did not offer more spots to people of color. They actually had the same number of invitations, but more students of color accepted their invitations because they felt more welcomed. And so what happened was the admissions committee members, they changed their behavior and they changed their outlook. And so when they were interviewing with candidates, the candidates felt like they could actually belong there. That made a difference. And that class was the most diverse class that they had recruited ever. since then, they've had more diverse classes, but just a small step like that really worked. And so they're recommending that admissions committees actually do have their members take the IAT. Then creating a culture where people feel personally responsible, that's where mentorship and sponsorship really plays a huge role in trying to foster diversity and inclusion and helping to understand and help people work through bias as they may be experiencing it. And, institutional behavioral changes is really important, and having the leadership be committed from the top is equally important to create guidelines, to create vision changes for the organization, and then be able to move it along, as is transparency. Being able to be accountable for whatever the actions are. So we tried this one thing, and we really thought it was going to work, but it didn't work. And so we're going to reframe, we're going to reset, and we're going to try something new. And organizations really need to be accountable to their members in order to make those changes. So the Be Ethical campaign is one that I like to talk about in my unconscious bias and diversity talks, because I think that it can really be applied to any kind of equity, right? And it really, what this campaign, again, spearheaded by Dr. Silver, is looking at the data, examining what the data is. What is our baseline? Where are our faults? What can we do about it? How can we change things intentionally using the data that we have? And then not only stop there, but then tracking and monitoring those metrics over time to really show that we are making a difference. And if institutions, if organizations would just adopt those strategies, you would find so much more movement. And there are several, from a society standpoint, there are national societies that have been doing different things to try to increase equity, gender equity within their organizations, it can work, right? And that's something that I'm working with my national organization, IDSA, to really do. And I've shared the Be Ethical campaign with them. I've shared my thoughts with them. And it really takes a strategy and a commitment by the organization. The other thing that really is important from an unconscious bias standpoint and increasing diversity is getting rid of the stereotypes, right? And flooding our senses with what a doctor looks like in healthcare. And so that we can take over the pictures of physicians that exclude certain individuals. The images in our mind when we think doctor, when little kids draw doctor, they should be drawing diverse doctors, because that's what we are. And so there's a lot of different campaigns on social media really trying to bring this to fruition. There's the Black Men in Medicine campaign, Black Women in Medicine, there's Docs with Disabilities, and, didn't you start Latinas in Medicine? Right. So there's Dr. Duma started Latinas in Medicine, and so there's different groups that are trying to really show that doctors can come in all shapes and sizes and colors. And if we as allies continue to promote this, then we will find, hopefully, down the line that unconscious bias in healthcare towards healthcare professionals really will be decreased, because our frame of reference, remember, the connections that our brains are making are based on the things that we see. And if we're seeing this, then no longer, hopefully, would physicians that are not white men be asked whether or not they're really doctors. Okay? So, in summary, we talked a lot about unconscious bias. It is pervasive. It's quite prevalent. Everybody has it. We cannot get rid of it. Okay? We cannot get rid of it. But we need to address it in order for us to get to equity. Thank you, guys. I really enjoyed talking with you. I'm happy to take any questions if you would like, and get the floor open